Hi everyone, welcome to our Friday webinar series. I'm Dr. Prasad, head academics at Yashoda Hospitals, High-Tech City, Emergency Department. So today we bring forth you a very interesting topic, which is a very commonly encountered in our emergency department day in, day out. So which is dyselectrolytemia. So to know how it has to be structurally approached, we have a very eminent speaker, Dr. Arun, who is a consultant critical care at Birla Hospitals, Gurgaon. So over to you, Dr. Arun.
Yeah, good evening. It's a very hot day in Delhi, the kind of day that actually triggers off dyselectrolytemia in certain people. So I would like it's one of the topics that I think electrolyte imbalances is the kind of topic. The more you read into it, every single time you find a small nuance that helps you manage a patient better. And I always feel that being I am myself in critical care, but like being in emergency medicine, the time to react that emergency medicine doctors have is much smaller than the time that critical care doctors have. Because critical care, at least we have a baseline picture, we have some labs that are established, but in ER you always don't know, you don't have a barrier with the patient party. So yeah, the reason I picked this topic today, that is dyselectrolytemia, I'll be focusing on sodium and potassium primarily today. If everything goes well, we can discuss on further electrolytes some other day. But the reason why I picked these specific electrolytes is that when I was in my first year in CTCCM, one of the first things that my consultants had told me is, as medico legally speaking, you can miss a lot of things, but if you miss a sodium correction, or if you lose a patient due to sodium correction not being done at the right time, or you lose somebody because of a change in potassium or something that you have not planned for, or you lose somebody because of hypoglycemia, it becomes very impossible, almost impossible for you to be saved in a court of law. That is why, as a senior consultant, as HODs, they will not pardon something like this that easily. That's why this has to be focused very well. And it's one of those checklist things that you have to do whenever you see a patient, whenever a patient comes to the ER with you and you do a blood gas. And one of the first things that you should focus on, because there is a tendency that you tend to focus on the acid base component, or you tend to focus on compensation, but sometimes electrolytes are kept out. So this is one of those things that we should not miss. Okay. So yeah. So as sir had already introduced me, I basically work as a consultant in critical care. I practice primarily in Gurgaon, but I do have a clinic in Delhi also. Uh, so today I'll start off by, basically, this is common knowledge that sodium levels in our body are in the range of 135 to 145 milliequivalents in the serum. Potassium is considered to be 3.5 to 5.5. Easy mnemonic is that you invert the something that you were taught in medicine in first year, that 3.5 to 5.3. That's how you remember. For calcium also, basically September 11, 9/11 is the general range that is given. So those are the things that still have stuck in from med school. Uh, so sodium, it's one of those things that always works in synchrony with water. Sodium and water generally travel on the same side, while potassium goes the opposite direction. Sodium is responsible for a host of functions, including neuromuscular functioning. It helps you balance fluid levels in the body. Potassium is more concerned with the cardiac as well as the muscular components. So whenever a patient comes to us and let's say they present to the ER and they have either they are dehydrated, or you feel that they have all their sensorium is altered, they are drowsy. So one of the things that we should always look for is hypernatremia. Sodium above 145 milliequivalents is hypernatremia. It can be because of a person restricting their water intake, can happen during fasting. Uh, or a person having a higher amount of salt. It happens if somebody consumes food that is rich in sodium. Chinese food is one of those things. Otherwise, a salt-rich diet also. Uh, a lot of free water loss that can happen during summers, during dehydration, and burns and extra renal components are also there. So, as I mentioned, the symptoms of hypernatremia include irritability. Generally, a patient, even when you talk to them, they don't respond very well to responses. There could be spasticity. You could also sometimes see seizures in such patients. When we look at the monitor, generally such patients, there will be tachycardia because of the perceived loss of fluid. There will be hypotension. The classical features that we see, like sunken eyeballs and all, are more for pediatric references. But adults, at least, you can see the skin turgor, and you can see the dry mucosa. That is one thing that we have commonly seen. So, a person coming to us with hypernatremia, where we have clear evidences that they have not that it is of a acute case, uh, that can be corrected rapidly. But patients with chronic hypernatremia, the protocol of correction is always a bit slower. Sodium is one of those electrolytes we cannot correct very rapidly because the rapid change in a sodium correction has a direct effect on the CNS, and it affects the myelination of the CNS. Uh, I did, I'll come back to it later, but patients with uh, pontine melanosis or osmotic deregulation syndrome, I have just seen one patient in life, and I remember that patient very vividly because he had that classical response where he could only move his eyes. Everything else was kind of locked out. Okay. So, generally, I see you should always keep hypernatremia in mind for a very specific for a subset of patients. Uh, Pediatric patients is a possibility, but I don't deal with pediatrics as much. But the patients that I have seen hypernatremia very commonly is older patients, geriatric patients. Geriatric patients generally, with or without a caretaker at home, do come to us with electrolyte disturbances. So they are the people we always keep an eye out for all electrolyte imbalances. So normally, when a person comes to us with a sodium anomaly, our target aim for correction with the sodium anomaly is around 12 milliequivalents in a 24-hour cycle, approximately zero point 0.5 milliequivalents every hour. Uh, so, one of the things I would always like to stress is if any patient comes to you with electrolyte anomaly, the first thing that should be on your mind is you have to always assess the patient's volume status. Without assessing a patient's volume status, you cannot comment on the electrolytes because the moment a person goes into a euvolemic state, then the electrolyte picture will also change accordingly. Because as I had mentioned earlier, sodium and water go hand in hand. So if a person comes to us with, say, hyponatremia, and we initiate measures to remove the fluid from his body, then the moment the volume correction happens, his sodium will also get corrected. So the same thing we have to maintain. We cannot do it very rapidly. Uh, Potassium also, because when we see these anomalies, we see them in subsets of patients who have either renal impairment, who have cardiac impairment, or who have hepatic impairment. All of them have presentations which are a little bit different from each other, which we can assess even on the blood gases if we have a keen eye. So I would always like to say that if suppose a person comes to us in the ER, and if you do have uh, like an ultrasound facility available and you are able to assess the IVC, that is a very good thing that you can do. We do ultrasound of the lung also. So we are able to see if there is an effusion or if there are A lines or B lines on the lung listing parameters. And obviously, a history of the patient helps. All the three factors that I mentioned, hepatic impairment, renal impairment, or cardiac impairment, all of them will lead to slightly different features. So in the hospital that one of the hospitals I was working previously, they had a very prominent gastroenterology hepatology program, and they were a decent center for renal transplants, for both renal as well as liver transplants. So, in such patients, one of the classical pictures that we had seen is that a person will come to the ER. He will have a failure component to it. He will also have the sodium will be he will go towards the hyponatremic side, because there is a dilutional hyponatremia in such patients. At the same time, because such patients are on potassium sparing diuretics, so he will have hyperkalemia. Hyperkalemia along with respiratory alkalosis, along with uh, hyponatremia. Generally, those patients tend to be from the liver, with the liver impairment or CLD patients. Uh, CKD patients or patients with chronic kidney disease, they do have fluid overload. If we take a history, they might not have been very regular with dialysis, and generally they do present with hyperkalemia along with acidosis, because a person having CKD over a period of time starts developing chronic uh, metabolic acidosis. And any person coming with cardiac failure, you will be able to see with the pattern of their breathing, as well as when we do ultrasound and we see their fluid status, we do take a look at the heart also. You are more likely to find a dilated LA or RV. So those are the possibilities. So a person coming to us with hypernatremia, but with euvolemic status, generally, if we supplement with either free water or we supplement with dextrose, the excess sodium will get secreted in the urine and the hypernatremia will get corrected. Uh, a person coming with hypernatremia and hypervolemic status, which is the presentation that happens, as like I had said, with cardiac failure patients, that is a possibility. So generally, we give Lasix infusions or we give furosemide, along with we give free water replacement also. And diuretics in such patients have to be used very carefully, because excess of diuretic in such patients will lead to rapid corrections. And hyponatremia is a very detailed topic. It's a very good topic. We do have the entire algorithm to follow. But hyponatremia, which we have seen very commonly, it occurs in geriatric patients who present to the ER. Uh, the, I think the primary cause that we have seen in geriatric patients is that what happens with them is they are generally hypertensive patients. They have specifically been told to avoid a salt-rich diet. So gradually, the salt in their diet is restricted, but their fluid intake remains good to normal. Secondly, people who follow yogic practices or who follow naturopathy, they always stress on water intake. So older patients, we have to categorically counsel them that water intake has to be in proportion to their cardiac output or in proportion to their ejection fraction. Otherwise, an excess of water just leads to problems in them. So that's one of the patients that we see hyponatremia commonly in. Like I had mentioned earlier, hyponatremia correction has to be very gradual. Once we are able to assess the volume status, and only then we initiate measures to correct the hyponatremia. So this is the protocol that we follow. We effectively, we first of all are able to see whether the person has a serum osmolality that is normal, low, or high. With a normal with a normal serum osmolality, we have to rule out protein intake, and we have to see hyperlipidemia. A person with low serum osmolality, those are the people we have to assess volume properly, and a person with higher serum osmolality, we have to rule out hyperglycemia. We have to rule out diabetes. Evaluation has to be done in such patients, along with any previous history of mannitol or sorbitol intake. So, like I said, volume status has to be assessed. A quick way to assess volume status in such patients is uh, we give. There are both ways of assessing. Ultrasound at the bedside is now becoming more and more common. So an IVC assessment of such patients, generally we see that an IVC that ranges between 1 to 2 centimeters along with the collapsible wall. If we go strictly by the books, then IVC assessment is truly applicable for patients who are ventilated. But this gives us a reasonable benchmark that we can work with. So an IVC that is full uh, generally indicates that the patient has good volume status. An IVC that is collapsing means we do have some leverage to give more fluid. And a dilated IVC obviously means that the person is full to the brim with fluid. We can't give him any more. The second thing is that we use commonly is we use a cardiac marker. It is called NT-proBNP, and NT-proBNP levels, but generally they take 1.5 days to come. But NT-proBNP is also a very good indicator of somebody who's going into cardiac failure. And elevated levels of NT-proBNP indicate that the person is on chronic fluid overload. So those patients, we need to do fluid restriction. We need to give them diuretics, and ideally, we need to do what is called as we need to do serial NT-proBNP assessment. We generally check their NT-proBNPs every 3 days, and if we see that with diuretics and fluid restriction, it is coming down, then that is the lifestyle choice that they have to make. So let's talk about something that is considered very controversial in critical care, definitely. That is the use of hypertonic sodium. So hypertonic sodium we always use with a lot of caution. It is because, like I said, without assessing the volume status, it is not feasible for us to give hypertonic sodium, because the moment any change or any switch in the volume status occurs, because of the elevated levels of electrolyte or sodium in the blood, the person's sodium gets rapidly corrected. So 3% saline, the places that we use nowadays commonly is generally it is for patients who have CSF raised intracranial pressures. So raised intracranial pressures, we use that as an osmotic agent, because 3% saline generally what happens is it will take fluid away from the CSF, and it will help us maintain a lower CSF pressure. So in patients with any space occupying lesions or post any cranial surgeries or patients with evolving hemorrhage, those patients are the ones in which you use 3% saline. A person coming to the ER with hypernatremia, we have to use 3% saline very cautiously. We generally don't indicate it till at least we have a beginning level of lab investigations that are done, which include, like I said, if we have an NT-proBNP, if we are able to assess the fluid status using ultrasound, along with a lab regulated assessment of all your markers. We have to be careful about hyperglycemia also, because hyperglycemia also gives you erroneous readings. So this is me covering sodium broadly. Like I said, sodium, there are certain things I'll always circle back to. One of the first things I said is you have to be very careful with sodium management in geriatric patients. Uh, I have seen almost now close to 8 cases of normal tension hydrocephalus. So normal tension hydrocephalus, like when we see it in medicine, you always remember the acronym weird, wet, wobbly, because there is altered sensorium. The patient tends to be incontinent, and the patient has gait changes. So weird, wet, wobbly. Yeah. So it is considered a diagnosis of exclusion. So once we are able to rule out every single thing, then finally we come down to normal tension hydrocephalus. But it is seen very commonly in geriatric patients. So that is one thing we should always keep in mind. Generally, in such patients, when we correct their sodium, uh, the symptoms also subside. So that is something we should always keep in mind. So now, if sodium affects the brain as so as to speak, I think potassium is more intricately linked to the heart. That is why potassium always puts both the cardiac as well as the kidney specialists in a bit of a dizzy. So the normal levels of potassium in our body are between 3.5 to 5.5. Uh, any levels above 5.5 are considered hyperkalemia. So uh, as in just like in sodium, in hyperkalemia also, we have to first take a history of what the person has been doing. So if there is, generally there is a gut block to the amount of sodium or the amount of potassium that you can have. Compared to IV, generally with the gut, it requires a very higher level of sodium for you to raise the level of potassium marginally. But if a person is, if somebody is used to say coconut water, so those are the those are the people you will see that they have a higher level of potassium. Second thing that we have also seen is certain renal patients, not renal patients, hypertensive patients. So hypertensive patients nowadays, that you give them specifically, you tell them that they can't have uh, a sodium-rich diet. So what FMCG marketing companies have done is they have started marketing salt, which is low in sodium. So the low in sodium, the saltiness of that salt comes from potassium with higher doses. There is a specific brand. It's called Luna or Lona. So I have had patients coming with the same problem, as in they only take salt, but that salt is Lona. So effectively, they have high potassium levels, but sodium levels are normal. So diet, we definitely have to check. Secondly, if there are any drugs that cause an increase of potassium in blood, most commonly being potassium sparing diuretics. So somebody with cardiac failure or somebody with hepatic failure, if we start them on diuretics, say spironolactone, then over a period of time, their potassium levels remain more than 5. So that is something that we have to titrate. And like I said, potassium-rich diet. Uh, Potassium-rich sources include bananas. They include coconut water. Those are the common ones that even athletes use. But like I said, this salt that is rich in potassium, that is also something that we have to rule out. So for whenever we have to treat, so hyperkalemia is something that causes rapid arrhythmias developing in patients. So the treatment measures include, we can give diuretics, then we give a glucose along with an insulin infusion. The glucose insulin infusion, the mechanism being that insulin, when it causes an uptake of glucose into the cell, it also causes an uptake of potassium. So potassium effectively moves into the cell along with the glucose, and that causes the potassium levels to go down. Uh, One more, since acidosis aggravates hyperkalemia, so sodium bicarb infusions can also be given. But sodium bicarbonate, we have to be a bit careful. It does have an effect on the heart. We should not give a rapid infusion of sodium bicarbonate. Hypokalemia is effectively the levels of potassium are lower than 3.5. So generally, we see this in cases where there is an exaggerated loss of potassium. It could be in diarrhea. It could be in excessive diuretic use. Malnutrition is also one of the possibilities. And endocrine conditions like Cushing's and hyperaldosteronism. So when we correct potassium, like I said, first of all, we have to make sure that what is their renal cardiac status, what is their drug history, what is their diet. Once all these things are factored in, uh, the potassium correction that can be executed for a person over a day, the rule that we follow is we have to give at least 100 milliequivalents of potassium over a 24-hour period. This is when, if there is what is called, if the person is average 60 kilogram person, along with passing normal amounts of urine and stool, and having normal diet and appetite. If the person weighs more, the correction can go up till 200 milliequivalents also in one day. Generally, a person with proper intake and exchange of potassium, 100 to 200 milliequivalents can be given in one day, provided his urinary output is good and he's passing his usual motions. Other than that, if there is aggravated loss because of, say, urination, or because of, say, recurrent loose stools, then the potassium also has to be given correspondingly. One more thing that should be considered is that potassium and magnesium also have at least magnesium has a stabilizing effect on potassium. So a person who's having recurrent hypokalemic episodes has to be supplemented with magnesium as well. So, like I mentioned today, whenever we assess electrolytes in a patient, we have to, first of all, be very clear about what is their volume status. We have to account for all the factors that cause a change in the volume status, which include the cardiac, the hepatic, and the renal function. Geriatric care patients are a specialty because of the reasons I mentioned. They have all these components along with a dysregulated volume. Once we have a baseline assessment of this, a rapid correction should be done. So blood gases are one of the easiest ways for us to track electrolytes when we are waiting for lab results. So, thank you.
Thank you. That is very crisp and in detail, at least for the ER perspective, it is in detail. They can, those who had listened to this webinar would be able to manage slightly better than what they're doing in the current practice. Yeah, thank you so much. I'll check the questions in the chat box. So there are no questions as such. So thank you so much for your time.
Thank you for inviting.
Thank you. Yeah, we'll end this session.